This is Justine Spargo recording Learning Plan 8, the Family and Childbirth Needs and Care. So this would be Chapter 18, 19, and 22. All right, so let's go through our objectives for today. So our objectives are to identify admission data that should be noted when a woman's admitted to the birthing area, compare methods of promoting comfort during the first and second stages of labor, explain the immediate needs and physical assessments of the newborn following birth, describe the role and responsibilities of the nurse in the management of a precipitous labor and birth, compare the major types of regional analgesia, anesthesia, including areas affected, advantages, disadvantages, techniques, the nursing management of laboring woman and her fetus. Describe the nursing management for laboring woman and her fetus related to general anesthesia. Describe the use of amniotomy and the nursing management of a woman and fetus. Compare the methods for inducing labor, explaining their advantages and disadvantages in determining the nursing management of a woman during labor induction. Describe the measures to prevent episiotomy, the types of episiotomy performed, and the associated nursing management. Explain the indications and maternal and neonatal risks that impact nursing management during forceps-assisted birth. Describe the use of and risk of vacuum extraction to assist birth. Explain the indications for cesarean birth, impact on family unit, preparation, teaching needs, and associated nursing management, and then explain the risk, guidelines, and nursing management of the woman undergoing a trial of labor after cesarean. All right, so nursing management during admission. So first thing that we need to do is make sure the mothers know when she should be coming into the birthing unit or notify her healthcare provider. When they get there, make sure you give them a quick yet thorough orientation that includes the location of the restrooms, public phones, nurse call or emergency call light system. Explain the monitoring equipment or other technologies that will be used. This will all help the woman and her partner to feel less frightened by the environment. Also, we may want to tell the mom when to come back to the birthing unit. So a lot of times we tell them if there's a rupture of membranes, if there's regular frequent contractions. So for nulliparas, so moms who've never had babes, so a lot of times we say if they're 5 minutes apart for 1 hour, then come in. Multiparas, women who've had more than one birth, we usually tell them when it's 6 to 8 minutes apart for 1 hour, we want them to come in. And then if there's any vaginal bleeding, because that is not normal. And then if mom's not feeling baby moving around a whole lot, we may have them come back in and be checked. If ever you're in doubt, you could say if you feel really worried about it, go ahead and come in. We'll check you over instead of kind of blowing mom off, because you never know what's actually going on with her or babe just over a phone conversation. And it helps kind of save your behind. All right, initial care of a newborn. So we use an APGAR system when babe is born. So the APGAR system will give a rating at 1 minute, and then we do a rating again at 5 minutes. And then the maximum score there is a 10. Scores 7 to 10 basically mean that newborn's in good condition. Maybe they had some suctioning or maybe blow by blow with oxygen. Below 7 would be resuscitative measures, and then less than 3 at 5 minutes would be neonatal mortality. So in this APGAR scoring, we look at the heart rate, respirations, the muscle tone, the reflux or irritability, and then the skin color of the baby. So you can see here's one example on the sheet where it shows the heart rate. If it's absent, you get 0. If it's less than 100, you get 1. If it's greater than 100, you get 2 points. So it's a point system. Respirations, if they're absent, 0. Slow or irregular, you get, or a weak cry, you get a 1. 2, good vigorous cry. Muscle tone, if they're not moving at all, they're just limp, that'd be a 0. If they have some flexion of extremities, that'd be 1. Really good flexion, active movement would be 2. Reflex irritability, if there's none, that'd be a 0. If they have a weak cry and grimace, that'd be a 1. 2 would be a real vigorous cry, cough or sneeze. And then skin color, so if they're blue, that's a 0. Acrocyanosis, so the arms and legs may be blue, but the central body's pink, would be a 1, and then a 2 would be the whole body's pink all over the place. Now, to palpate the heart rate for a newborn baby, we're not going to put the stethoscope on them and feel. Usually there's a whole lot going on. So what we do is We feel between the umbilical cord and the skin after it's been cut, and you feel right kind of on where that belly button would be, right where the umbilical cord goes into the skin. And we feel that. That's the most important part of the assessment. And we usually feel that for 10 seconds and multiply it, or we feel it, yes, for 10 seconds, and then we multiply it by 10. Um, and so then that can tell us what the heart rate is without actually listening for a full minute. That'll give us a quick assessment of what the heart rate is. Here's another one showing the APGAR score. So always remember that if a baby isn't stable, then the parents won't be able to hold them or spend time with them until they are stable. So another important thing that needs to happen next to the initial assessment of the babe is the identification bands need to be placed on mother, father, or significant other, and then two of them on the babe. Usually one's on the ankle, one's on the wrist, and then there's usually an activation of some sort of alarm system either on the ankle or the umbilical cord. So that way, if babe leaves the OB unit, then alarms go off. So that way, someone doesn't feel the baby. All right, let's talk about lochia. Okay. So after the fourth stage of birth, the fundus needs to stay well contracted to help clamp off the blood vessels in the uterus from where the placenta was actually attached. So without the contraction, the mom would continue to bleed profusely and potentially hemorrhage. To aid the mom, we give them short doses of Pitocin to contract the uterus right after the placenta is delivered, and be given by IM or by IV. And then babe's usually given to mom to initiate breastfeeding. That will also clamp down on the uterus, or we can do a fundal massage the fundus, which can also trigger the contraction and clamp down on the uterus to help slow or stop the bleeding. The first 4 hours after delivery, and at regular intervals, the nurse will do a fundal check or massage to ensure it remains contracted. The fundus is typically located at midline at or below the umbilicus is usually where it's at. If you palpate and it feels kind of soft and squishy, we call that boggy. And if it feels boggy, we then want to massage it because there's pooling of blood that's in there that can cause clots, and anything left in the uterus prevents it from actually contracting, and then mom will continue to bleed and she could hemorrhage that way. Now, the fundus may also appear to be higher or sticking up in the air. We can massage the fundus until it's firm at that time, and one hand's usually supporting the uterus on the bottom, and then the other one's usually on the top part of the fundus to push down to help express any retained clot. And this is usually something that hurts, so really be gentle as possible with mom. If it's off to the left or to the right, it may indicate that the bladder is full and has displaced the uterus, so you can always ask, do you have to go pee at all? The other thing is the lochia that comes out can be some different colors. So rubra is dark red, and that usually lasts anywhere from 3 to 4 days. Then we have serosa, which is like a pinkish brown color, and that's usually 4 to 10 days. And then we have alba, which is kind of a whitish or a yellow color, and that usually is from 10 to 28 days. And it should progress in that order. It should not go from alba back to rubra. That may mean that there's some sort of hemorrhage going on. All right, nursing care during precipitous birth. Precipitous birth means one that occurs rapidly without the doctor, usually occurs within 3 hours or less, so it's a real fast delivery. You always hear those stories of mom delivered in the taxi cab. That may have been a precipitous birth. Or in the ER, didn't even make it to OB unit. That could be a precipitous birth. So the woman, make sure that we attend to the woman, guide the infant's passage through that birthing canal, clamp the umbilical cord, and immediately transfer the infant to the nursery for care. So we need to focus on the woman and the delivery of the placenta and contraction of the uterus, so that way mom doesn't bleed out and whatnot. So when a precipitous birth happens without the doctor being there, a lot of times it's the nurses just delivering babe. The mom may actually be disappointed or frightened. They may feel abandoned, angry, or cheated because they've been with this doctor the whole time and doc wasn't even there to deliver their child. We need to work with the woman and keep her informed. We need to remain calm, help her control her breathing, and tell her when to push and pant when the baby's starting to crown. So that way she doesn't deliver too quickly and rip and tear. And we need to provide reassurance for mom, okay? Don't let her freak out at all. The more in control you are, the more in control she'll feel. Keep the bed together. Don't break down the bed with the stirrups at all. Keep the bed pushed together if you're in the OB unit. That way you don't have the potential for dropping the newborn on the floor because they are kind of slippery. We want to suction the nose and mouth so they don't aspirate upon taking their first breath. Very, very important to suction those out. Otherwise, like I said, they'll aspirate. All right, pain relief therapies during birth. So this is going to be chapter 19. All right, so there's two origins of pain. So there's perineal and then there's the uterine contractions, which we kind of touched on before. So the perineal is due to the stretching and the expulsion of the babe. And then it's local. It can be local from laceration or a tear that's happened in the perineum area. It can also be from uterine contractions, which cause the cervical dilation and the effacement. And then we could have ischemia due to decreased blood flow to the area. And then it can be transmitted through the spinal cord, that the contraction pain is transmitted through the spinal cord. Now the effects on newborns. So if we have pain medications that we want to give mom to help with the pain meds can affect the newborn. So pain and stress of the mother also affects the baby. Maternal respiration, oxygen consumption actually increase, which then decreases the oxygen availability for the babe. And then we can also lead to the metabolic acidosis, which releases catecholamine, which causes maternal blood vessels to constrict. Well, we don't want mom's blood vessels to constrict because when that happens, the babe doesn't get the blood supply and oxygen that it needs. Okay, so this just shows a deceleration that tells us that babe's not happy, maybe not getting the oxygen it needs. So its heart rate's dipping down because of maybe pain, or maybe they got pain medication. All right, pain management during labor and childbirth. Analgesics used in labor. So primary action is at the site of the brain, activating neurons that descend to the spinal cord. I can't talk. So we can use Stadol, fentanyl, Demerol, or Nubain are pretty common ones that we use. They're usually used early in labor and given intermittently or by a PCA, which is fairly uncommon. It's not entirely clear whether it really provides pain relief for mom or if the sedation effect from those pain meds help mom to cope and rest in between those contractions, which gives her the energy and the feeling like she has less pain. Make sure that we use caution with anyone who has a history of substance abuse, though, because if they're asking for pain, we can't say that they're not having pain, but know that they may be asking for pain meds for that high, or we may have to use more pain meds to give them a true relief of pain. Now, I like this little picture that's on here. It says natural childbirth class, and then on the door it says push hard. I just thought that was kind of cute. All right, narcotic analgesics. All right, so respiratory depression of both mom and fetus can occur. We need to make sure that we have Narcan or naloxone on hand used to reverse if there's respiratory depression. Narcan duration is shorter than that of an analgesic, so the nurse needs to make sure that they assess if the respiratory status starts declining and if they need another dose. So if I've given Narcan to reverse the effects, it'll wear off pretty quickly. So then I need to still pay attention because maybe it wore off quicker than the analgesic actually wore off. So I may need to give a second dose to actually bring that respiratory rate back up. Now, anyone who has an opiate dependency may go through severe withdrawal if given Narcan. So the healthcare providers need to proceed with caution. Okay. Nursing management. So complete assessments prior to any analgesic administration. So the best time for administering analgesic. So for nulliparas, a woman who's had no birth greater than 20 weeks gestation, we usually do that when the cervix is dilated 4 to 5 centimeters. And multiparas, which is a mom who's delivered 2 or more births at more than 20 weeks, is usually about 3 to 4 centimeters because we know that they'll dilate more quickly because their body's already been through it once. So giving this early will help eliminate the occurrence of respiratory depression for mom and fetus in the second stage where she's actually pushing. So we'd rather give it earlier than too late. Patient teaching. So women need to know about pain relief medications. So before giving them, they need to know the following. So they need to know the type of medication, the administration route, the usual effects of the medication, how will she feel, effects to the neonate or the fetus, and any safety measures. So like remain in bed with the side rails up, things like that. Now remember, the fetus feels the effects of the drugs too. So know the side effects of the medications you administer. Keep a dose of Narcan or narcotic antagonist readily available. And then the babe's fetal heart rate variability and patterns must be normal before we can even give it. So there can't be any indication that there's any risk to babe before we give it. Regional analgesia and anesthesia. So the most common methods are epidural block or intrathecal. It's used to control labor and birth pain. We can do a spinal block, which is an anesthesia for C-section. So they just block off from like the chest below and where you don't have any pain that way. You can have a pudendal block, which is during birth or prior to an episiotomy, where they just block a certain section of the peri area. And then you can also have like local infiltration, which is during birth or prior to an episiotomy. So it's just one local section, one small section that they're numbing up. So episiotomy, epidural risk factors. So they may be ineffective or provide patchy relief from pain. They can decrease your blood pressure, which can make you nauseated, lightheaded, things like that. They can increase the length of labor because now you don't have feeling to push adequately, which again, like I said, results in ineffective pushing, which leads to a vacuum extraction or forceps delivery, which is no good for mom or babe. You can get a headache or back pain from it, and you can have long-term spinal nerve damage because again, they're going into your spine to put it in. Adverse reactions would be like mild symptoms to cardiovascular collapse. So mild would be palpitations, tinnitus, apprehension, confusion, metallic taste in the mouth. Moderate would be like more severe degrees of mild symptoms, plus the nausea and vomiting, hypotension, muscle twitching, and severe would be loss of consciousness, coma, bradycardia, respiratory depression, and cardiac arrest. We don't want any of those. Now, pudendal or local. A pudendal is like a transvaginal, which intercepts signals to the nerve, and perineal anesthesia. And then there's that local infiltration, which is injected anesthesia into the subcutaneous and intramuscular areas of the perineum and used to repair like a tear or episiotomy. So it's to a specific area is where they're giving it. So it's kind of like if you get stitches, they just numb up the area around where you're going to get the stitches. General anesthesia. So the nurse should assess whether the mom ate or drank when they ate and drank last, because that'll play a part on the anesthesia and if there potential for aspiration. Administer the prescribed pre-medications such as an antacid, again, which will help if they have any aspiration, then it's at least not as acidic. We place a wedge underneath mom's right hip to displace the uterus and prevent vena cava compression, so then they're laying on their left side. We give oxygen prior to the start of surgery, so that way we know mom and babe are getting plenty of oxygen. They need to have an IV access, and then a common complication is fetal depression. So the fetal depression is related to the depth and duration of the anesthesia. They usually have lower 1-minute APGAR scores and higher incidence of metabolic acidosis, hence the oxygen for the mom. And then complications could include difficulty in maternal intubation, vomiting, aspiration, increased blood loss because of the uterine relaxation from the anesthesia. It's not going to clamp as well. And then difficulty remembering events for mom. So she may not actually remember baby even being born, which is unfortunate, but can happen. All right, so on page 411 of your book, you do have placenta previa, which is a complication that can occur. This is when the placenta is implanted in the lower uterine segment. It can be either low-lying, so it's close to but not covering the cervical opening. So like this one would be a low-lying placenta. It could be partial, where it's partially covering the over the cervical opening. You can have marginal, where the edge of the placenta is covered, and then you can have complete, where it's completely covered. Now, what happens here is they're not really sure why it necessarily implants down there. It maybe because of prior C-sections actually increase the risk, because the egg drops and then it attaches to some scar tissue, which when they cut mom open, it's usually down here in the lower portion. And so then it attaches there. So what happens is when mom begins to dilate, and then essentially the placenta starts ripping off the side of the uterus and starts to bleed. Well, that's where babe gets its oxygen supply and its nutrients. So now babe's limited on that, and now mom's bleeding. So this ends up in C-section inevitably. Okay, so we can't do any vaginal exams, because if we stick our hands up there and we actually hit the placenta, we can make it bleed, and then we could end up in abortion for mom, or mom bleeding out. So we usually have mom bed rest. We monitor for blood loss. If they have any bleeding whatsoever, they need to go see the doctor immediately. We monitor for pain or contractions. We monitor fetal heart rate, vital signs, hemoglobin, hematocrit, RH factor. We make sure that they have an IV and that they have blood ready for a transfusion if mom starts to bleed out. And like I said, it's a C-section that happens, and depending on where it is, if it's on the anterior part of the stomach, they may have to actually cut right through that placenta to get to babe, to get babe out. And then they have to make sure that they get babe out and they control mom's bleeding at the same time, since they cut right through the placenta. Then we have the abruptio placenta, which is the premature separation of a normally implanted placenta from the uterine wall. So it can be marginal, which it separates at the edges, and blood supply, or the blood from it, escapes vaginally. So that would be that first one, where it just kind of peels away on one side and then we see the blood. Mom will come in with bleeding. It could be central, so separates in the middle, and then the blood trapped and concealed, so we don't even know that it's happening because we don't see the blood. Maybe baby isn't growing as much. They're now all of a sudden small in their measurements, and this could be wise because they're not getting the supply that they need. And then they could have complete, where massive vaginal bleeding occurs, where it came completely off the vaginal wall, and we could have a hemorrhage. We would want to then measure the abdominal girth, which could tell us maybe how much bleeding is happening in there, because it's pulling in the abdomen. We don't know the cause of why it happens. It's painful vaginal bleeding that, like I said, can be concealed if it's in the middle. The abdomen's usually firm to like stone hard. We usually have a sudden dark red blood. Uterus may be enlarged and change shape, and it can actually cause DIC. And always remember, for both abruptio placenta and placenta previa, that the amount of bleeding from the vagina is not a reliable guide to the degree of the separation. So they could have a little separation and it bleeds a lot, or they could have a huge separation and it's only bleeding a little, because remember that cervix may not actually be opened all the way so we can see it all. All right, so let's talk about DIC. So it's disseminated intravascular coagulation. So damage to the uterine wall causes clotting with central abruption, and then large amounts of thromboplastin are released into the maternal blood. And thromboplastin triggers the development of DIC and hyperfibrinogenemia. So the fibrogen levels, which are normally elevated in pregnancy, all of a sudden drop within minutes, and then blood will no longer be able to coagulate. So you can't clot. So then we have hemorrhage. We end up with hemorrhage shock, renal failure caused by shock, vascular spasm, intravascular clotting. Small clots are formed within blood vessels that consume coagulation proteins and platelets. And then abnormal coagulation and abnormal bleeding results in various systems. So we could have microclots that disrupt normal blood flow to major organs and can lead to organ failure. So you get all these itty bitty tiny clots within your maybe your kidneys or your liver. And then if there's little clots there, leads to no blood supply to that organ and the organ dies. Okay. So bad news bears, we don't like DIC. All right, so treatment. Treatment includes maintaining the cardiovascular status of the mother and developing a plan for the birth of the fetus. So get the baby out now. C-section, we have major bleeding concerns because we know that mom's not clotting, but yet we need to get babe out. So we cut mom open. Now how are we going to get her to clot? So we need to cross match her. We need to get her a bunch of fresh frozen plasma and IV fluids to help maintain her blood pressure and keep her alive. All right, let's talk about birth-related procedures. All right, external cephalic version. So this is changing the fetal presentation. So if babe is butt first and we want to change the baby inside the mom's stomach, we're going to push on mom's stomach to try and get baby to switch positions. So it's like I said, it's used if it's babe's breech or shoulder presentation is detected. It's only about 50% successful. We need to do an ultrasound to locate where the placenta is and to confirm the fetal presentation before we do anything. They need to be at least 36 weeks in case there's a complication and we have to deliver by C-section. We have to do a non-stress test and NST to make sure that the fetus is well before we even start it and that the fetus can actually handle the manipulation because baby may not be able to handle it. And then we have bad news bears. Make sure that they're not engaged, so the head's not down into the pelvis because it's nearly impossible to turn it if it is engaged into the pelvis. And it can be painful, so encourage mom to take slow, deep breaths, try to distract them, talk to them in a very calm, reassuring voice. And then we want to continue to monitor mom's vital signs and the fetus for any changes. If there are any changes, we stop, and it is what it is, and mom has to have C-section. All right, let's talk about amniotomy, which ends up with artificial rupture membranes. So rupture membranes can be done by yourself where your membranes just rupture. Otherwise, these can be artificially done where we or the doc, well, usually the doc, ruptures the membranes. So amniotomy is the artificial rupture of the amniotic membranes, AROM. They use an instrument called an amni hook that is inserted through the cervix. Mom must be at least 2 centimeters dilated because it needs to be open enough to get it in there. And the fetus's head should be engaged before the artificial rupture membrane is done to prevent that cord prolapse from sticking out in there. Amniotomy can shorten a labor. It's more effective in multipart women because the cervix is more pliable. The amniotic fluid escapes and allows the presenting part to descend and put direct pressure on the cervix and dilate it faster. And then it also allows for an assessment of the color and amount, odor, presence of meconium or blood of the rupture membrane or the membrane fluid. So after the bag of water breaks, vaginal examinations are pretty limited to decrease the risk of infection. And then we take the temp every 2 hours. So now that, again, the bag of water has been ruptured, now there's an increased risk for bacteria getting up to babe or mom. Amnio infusion. So amnio infusion is where warm, sterile, normal saline or lactated ringers are introduced into the uterus through an intrauterine pressure catheter. Increases the volume of fluid in cases of oligohydroamniosis to relieve pressure on the umbilical cord. So when there's not enough fluid, because then when there's not enough fluid, babe may be pushing directly on that umbilical cord, creating pressure, which then baby gets unhappy, heart rate does all sorts of funky things. The compression would cause fetal heart rate decelerations and no reassuring fetal status. So the amnio infusion helps to perfuse the babe and can be used for preterm labor with a premature rupture of membranes. We do continuous fetal monitoring. We do frequent bed changes because you put that fluid in, it's going to come right back out. So it's kind of like doing a suppository, putting fluid in your rectum. And then we have to do frequent vital signs. All right, cervical ripening. I mentioned this a few PowerPoints before this. what doc may end up doing softening and effacing of the cervix, so that's cervical ripening. It's usually used in term or late term pregnancies when the cervix is unfavorable for induction. There's a pre-labor scoring system that's used to determine the odds of the induction will be successful. We use Cervidil or Cytotec, are two prostaglandin agents or synthetic prostaglandin agents that we use. It's commonly placed intracervically, so actually on the cervix or next to the cervix, or intravaginally to ripen the cervix. Commonly causes uterine stimulation, cramping, uterine irritability, hyperstimulation, which is contractions less than 2 minutes or more, or a contraction frequency of five or more in 10 minutes. So it basically makes you clamp down hard, and it makes mom's contractions last a long time as well. So it's not fun once it's kicked into the system. Labor can be pretty hard. So most women will say if they've ever been induced, they never want to be induced again because it makes the contractions harder and longer and labor a lot worse. It can be associated with uterine rupture, especially with those with previous cesareans or scars on the uterus. We want to monitor maternal vitals, electronic fetal monitor. We can do an NST ahead of time. Women may have to lay supine with a wedge under the right hip for 1 hour to let it dissolve and start working. Beta adrenergic agents may be given if hyperstimulation occurs to help slow it or stop it. Cytotec can also be given in cases of hemorrhage to actually clamp down on the uterus to stop the bleeding. So we give it to start labor, and we can also give it to kind of slow or stop labor as well. Or not really stop, I guess, labor. It'd be to stop the hemorrhage from labor. Intracervical catheter is a mechanical dilation used like a Foley catheter where the balloon is inflated. So they stick it up there. They stick it right along next to right up in that cervix area, and then they blow it up. It's hard to place and trying to keep it in the right position, and mom really can't move because it can become dislodged. And it's helpful though when it does work. It can really shorten that first stage of labor when mom's trying to actually dilate. So it comes up in here and it kind of blows up and it squishes everything off to the side and thins it real quick like. Labor induction and augmentation. So a lot of times we use Pitocin induction. So the goal here is to achieve contractions every 2 to 3 minutes that last for 40 to 60 seconds with progress of labor, and the uterus must relax to full baseline resting tone before or between each contraction. So there is a specific goal on this when we give this. Progress is determined by the changes in effacement, dilation, and station. Risk, again, is hyperstimulation that can be too frequent or too intense and can lead to decreased placental perfusion and non-reassuring fetal status. The nice thing here is that the IV can be decreased or stopped to decrease the contractions. If you're giving it in an IV form, you just slow the rate or stop it. And once true labor is started, the stopping of Pitocin will not stop the contractions. Stripping membranes, we talked about this a little bit before too. So it's like a stretch and sweep. So stripping or sweeping the amniotic membranes, the physician puts a glove finger into the internal cervix and then rotates it 360 degrees twice to try and separate the amniotic membranes from the lower uterine segment. It helps to release the prostaglandins that stimulate uterine contractions. It's very uncomfortable and can result in cramping, contractions, vaginal bleeding, and a lot of times moms may see that bloody show. So here in the picture, you can kind of see beforehand it's stuck right against that cervix, and then afterwards it kind of breaks that loose. So that way things can start dilating a little bit easier. Episiotomy. So episiotomy is a surgical incision of the perineal body to enlarge the outlet. So a lot of times we give a local anesthetic. We minimize the risk of lacerations. It's more likely the woman will have an anal sphincter tear if we don't do it. There's Two different types, there's midline or medial lateral. So you can kind of see where the two are. The medial lateral is kind of off to the side a little bit, and midline is directly straight down towards the anus. We a lot of times have blood loss from that, pain. They can have increased risk for infection because of the location, and then perineal discomfort. Moms usually have an increased risk if they're prima gravida, if they have a lithotomy position, if they have a large baby, if baby's in LOP or ROP, and if forceps or vacuum are used. Some preventative measures to prevent having to do an episiotomy can be a perineal massage. And yes, I said perineal massage. They'll actually put their hands down in the perineum to help stretch it. Natural pushing, so let mom push when she's ready and feels the urge to push. If they're in a side lying position, it may help. Warm or hot compresses. Firm counter pressure, so when baby's pushing out, you kind of push it back a little bit. Gradual expulsion of babe, so when we have her pants as baby's crowning, that'll help do the gradual expulsion of the head. Avoid immediate pushing after the epidural placement, because then again you have that immediate push. Forceps and vacuum assist. So these are surgical instrument delivery or operative vaginal delivery. Provides either traction or the means to rotate the fetal head to an occiput anterior position. Indicated in the presence of any condition that threatens the mom or the fetus and can be relieved by birth is when they use it. So fetal conditions include a premature placental separation, a non-reassuring fetal status. It can help shorten the second stage and assist the woman in pushing. It may be used when anesthesia has been used and ineffective pushing results. The cervix has to be dilated and the fetal position and station known before we even attempt it. And the membranes must be ruptured so that way we don't get a cord prolapse. The type of pelvis needs to be known so that way we know if baby can even fit that way. The bladder should be empty so that way there's no trauma to the bladder. No cephalopelvic disproportion can be present. Anesthesia need to be available if needed, if there's a lot of pain, or we need to take them to C-section. You need to have adequate staff also available if a cesarean is needed. And then you need to have mom's consent. You just can't do it because you want to. And doc does this. Nurses usually don't. We may have to get the equipment out for them. The equipment may cause ecchymosis and edema alongside the face. It can cause facial lacerations, brachial plexus, caput secundum, or cephalohematoma on baby's head. They could have facial paralysis, cerebral hemorrhage, fractures, brain damage, and even fetal death from using these. Women can have lacerations. They can have extending the episiotomy, making that cut longer. They can have bleeding, obviously, bruising, edema, and anal incontinence. And then a vacuum-assisted birth can't be left on longer than 8 to 10 minutes, and it usually slips off pretty frequently, and I'll show you what that looks like. And a lot of times a caput will disappear within 2 to 3 days because I'll have kind of a little cone-shaped head from the vacuum going on. But yeah, you can only let it slip off, I think it's like 3 times, and then they don't use it anymore. And they may yell for, "Get me the Kiwi," because that's a specific brand. So there are different brands out there. All right, C-sections. Cesarean birth is birth of the baby through an abdominal and uterine incision. Indications may be placenta previa, cephalopelvic disproportion, placental abruption, active genital herpes, umbilical cord prolapse, failure to progress, non-reassuring fetal status, previous classic incision on the uterus, more than one cesarean birth, malignant tumors obstructing the birthing canal, medical disorders like maternal respiratory disease, CNS disorders, intracranial pressure, mechanical vaginal obstruction like an ovarian mass or fibroids, if they have HIV, a mental illness. These are all reasons to have C-sections. Breech presentation or congenital anomalies, Rh alloimmunization may also be a reason why they choose to do C-section. There is an increased maternal mortality rate due to infection. Their hypertensive disorders or reactions to anesthesias, blood clots, and bleeding are all risk. Incisions can be transverse or vertical. So transverse commonly used and is hidden well within that pubic hairline. So it's bikini cut. Vertical is rarely used, but it's quicker and preferred in non-reassuring fetal status when rapid birth is indicated, or with preterm or macrosomic neonate, or a woman is slightly obese, not slightly, significantly obese. Uterine incisions, again, common lower uterine segment, the transverse or vertical. A classic vertical incision with the upper uterine segment cut, but almost never performed because of more blood loss and difficult to repair, and an increased risk for uterine rupture with subsequent pregnancies, labors, or birth. Vaginal birth after cesarean. So it's a trial of labor after cesarean, or the TOLAC, previously called the VBAC, is an alternative to repeat cesarean. So we need to have immediate access to perform emergency cesarean in order to do it. We need to make sure that we have an in-house anesthesia. They have to have in-house round-the-clock obstetric services and may have to travel to a larger hospital to do it. So our small little hospitals don't usually do them because you're a high risk for having your uterus basically, I don't want to say explode, but rupture. Guidelines also include 1 to 2 previous C-section births, low transverse uterine incision, so that way you don't have that rupture of the uterus because it's already frail where it's been cut open before. You need to have an adequate pelvis because, again, if your pelvis isn't the right size, no matter how much you want the baby to come out that way, it may not happen. Absence of other uterine scars, allowed to go into spontaneous labor, so you don't get to pick the day that you want to have the baby. And then complications could, again, be uterine rupture, infection, thromboembolism, or hysterectomy. And that's the end of the slideshow.